So yeah, the topic is how to manage non-dilatable and heavily calcified tibial vessels. And I'm going to start with a case, because in 8 minutes I have to cover this topic, so I decided to make it interesting with the start. 67-year-old male that does not believe in doctors and medicine. That's my Western Texas population. Spends a significant portion of income on chelation therapy, presents to our office with ulcer and claudication, history of cabbage and AAA therapy, rest pain for 5 months in left lower extremity, injured his toe and developed a worsening ulcer, and comes in and have been to multiple places before, he said, and nothing was done. I discussed this case in detail with Dr. Saab as well. So we started the consult in the office, going over everything with him. And if you could see, there is mild calcification there, if you can say. Heavily calcified, you don't see other vessels. I don't know where it's going to end. If you look at it, we think that's where the vessel is going to be. A lot of calcification, and this calcification is really different. It completely takes over the vessel. We went to dissections, and we discussed a few cases with Armani regarding lower extremity, below the knee calcification, and that calcium and that intima and that vessel wall morphology is completely different than what we have in other regions of the body. It completely takes over the vessel. So we don't know where the vessel is. We are thinking this might be the place where the vessel would be. So doing angiography, okay, we see something over there, and we're trying to wire it, going with our catheter, okay, and with great difficulty the wire goes in. We try to go in with different balloons to see if we can dilate, couldn't get anything, so undilatable vessel. And we're now questioning where our wire is. We're not even sure if that's a vessel or if that's piercing the calcium, going through different kinds. Let's see if we can just use the laser to make a hole in, or see the proximal portion. We can do a little atherectomy and nothing. No other vessels, so type 4 CTO. Dr. Saab really likes to talk about that. So what's our solution then? We said, let's decide to take advantage of pedal access. So these kinds of vessels, you have to be well-versed with CLI therapy. So Mehdi once presented a case in one of the meetings where you talk about when you have cases like this, you have to access at different points because every kind of a vector will help you, and that's what happens. We went through the peroneal artery, we flossed and tunneled, and we decided, okay, this might help us. So we came from above. Again, we used the balloon. Nothing would go up. Balloon not advancing in an antegrade fashion. Again, you cannot dilate. Went with a atherectomy, wouldn't pass. Then retrograde balloon angioplasty, and that gave us something. But again, there was still resistant in the vessel. So we start, this guy needs his leg. He's from Western Texas. What's our solution? So we said, we repeated the orbital atherectomy. This time, we came again after using a lot of medication that I want to talk about that, and 2 techniques that we use were, one is sequential balloon angioplasty, then scoring balloon angioplasty. We prepped the vessel well, wouldn't stay open, and we went with stents because we have seen drug-eluting stents have given results in a few of the trials that were done in Europe and North America. We have a meta-analysis coming out soon on that. So, and this is our results. So pretty good result. We're very happy with that. Now, we do have access point spasm because that's when we went to, but it's fine. So a combination of various different things. We talked about accesses. I'm not going to go into details of that. But medication-wise, Dr. Charji is sitting here. We came across different combinations, and this is what one thing we came across. We call it a Tex mix that we use in our very calcified vessels. It's a combination of verapamil, adenosine, nipride, and nitro, and we put it in a different, it's not a trade secret. The paper will come out soon on one perfect combo of the dosing of these medication. But you have to keep in mind when you're using these medications about the blood pressure of the patient, because these patients have multiple comorbidities, and sometimes to get pedal access, you have to put them into MAC, and you have to just be careful about the blood pressure on these patients when you're using this therapy. So I like not to use it as a drip, more so I use it as on-the-go injections. The other tips is the sequential balloon angioplasty. So these are vessels. I went in once in a very calcified peroneal artery, and with a 2O balloon, a very small 2O balloon, I cracked it, and I ended up having a perforation. And I went in to do the tamponading that perforation, and it kept on increasing till the point that I literally in that vessel, perforated vessel, decided to use a very variant technique, go in with the CSI atherectomy, then tamponade it, wouldn't help, and I end up putting a stent in because it was the only option, because no matter how much you tamponade, whatever you do, that spicules of calcium wouldn't let it heal. And this was fairly recent. So sequential balloon angioplasty, you start with a really small balloon. You start with a 2.0 balloon, then go 2.5, then go 3.0, then 3.5. Yes, you have to be very careful using a lot of these devices, but sequential balloon angioplasty in these very calcified vessels have helped. The other thing is scoring balloon. We used scoring balloon once. That's what we used to do. We came up with a technique. Scoring balloons, when you're using it inside, other than chocolate, where the other balloons have wires in it, it usually shaves just one side. So you bring the balloon out, you turn it, you bring it in, and you cannot move the balloon if you're turning it from outside, unless you move it back and forth. And using that really helps. In different techniques, just putting it in, turning the balloon in different ways, it helps to give you some kind of a vessel form. Because this calcium that I saw in dissection completely takes over the vessel, so whatever you can get from the vessel, take it. I'm just going to briefly talk about some studies, LAC studies, 145 patients, 155 of them critical limbs, 423 lesions, 41% SFA, 15% popliteal, but 41% of those were infrapopliteal. 70% patients had combined occlusion and stenosis, 29 Rutherford 4, 71 of those were Rutherford 5 and 6, and the limb salvage 92 at 6 months. So this clearly shows you that this is important. Looking at the definitive study, if you look at the CLI patients, 275, one-third of them were CLI, and look at the 78% patency in these patients. So in short, calcified infrapopliteal disease is more common. Developing arterial calcium is necessary. And there are many devices available. We're just going to skim through that. Some have more data than the others, but there is still lack of comparative data, and it's defined definitive between operators, how they prefer to use. There has to be a treatment strategy for patients in CLI, and that is a treatment strategy, but a lot of people come up with their experience in these fields. It is different calcium. It's a different vessel, different vessel wall morphology, different intima, and that's the reason. Sometimes when you see these vessels, you can see on fluoroscopy if they're completely taken over with calcium. There's sometimes we do the modified Schmidt technique that Jam talks about, and you go into these vessels and you'll get some of your leeway with your wires and catheters, and then you just have to keep on working to get whatever lumen you can. So these are the devices, the commonly used one. I just mentioned the ones that I commonly use: directional atherectomy or TurboHawk, Hawk 1 for eccentric and so constrict region, fibrotic or calcified, and you can use it till even the plantar vessels. Rotational atherectomy ones, Jetstream, Phoenix, Rotablator, and for thrombus, Jetstream is essential. SFA and tibial vessels, Jetstream, popliteal to tibial, you can use the Athromed, the Phoenix, but I didn't have much success with that, and Rotablator for the tibials. The orbital atherectomy, the CSI Diamondback, is very helpful for calcified to highly calcified lesion as compared to the moderate ones in these, and much success with those. And then the laser therapy and the cracking thing, which I think Dr. Shemus will talk about. So I'm not going to go into details of this. So atherectomy, the calcium 360 trial, 50 patients, 25 randomized to atherectomy with CSI and PT, and 25 to PT only. No significant difference in primary endpoint. 30% residual stenosis without Bailout stenting, but freedom from TLR, 93.3% in those patients. So then we combined the study. We said, okay, let's see what is out there for all these lesions. And we also included above the knee, and we included below the knee. Got some of my fellows together, sit into one room, got our statistician from the university, and we sat down, came up with this. So I'm going to end with this study that is going to be published soon. And primary outcomes included TLR, amputation at 12 months. We used all the studies that I ever published, all the case series, everything which is out there. Secondary outcomes, vascular complications, bailout stenting, and all-cause death, and fixed effect we used for that. Our results were, we got 9,874 patients, 3,000 in atherectomy and 6,000 in the PT-only group. Baseline characteristics showed all these were old patients with 68 years old. That was the average age. Primary outcomes were target TLR 16% versus 30%, and amputation rate at 12 months was 14 compared to 16 in the atherectomy group compared to the PDA. Secondary outcome analysis showed vascular complications 7 versus 9%, and bailout stenting was 27 versus 10%. There was no all-cause mortality. So you see the trend clearly shows slightly better towards amputation, no difference in all-cause death, slightly better towards bailout stenting. Vascular complication also trend shows slightly better in the atherectomy group. And you see this over here, the advantage of TLR in these population. So ending note is outcomes calcification needs atherectomy, safe and effective, and is feasible in the management of the disease. Each device type has specific strengths and weaknesses. One has to individualize the atherectomy device based on the morphology and anatomy, and it has to be case-based. What the future is different combinations of drug that's in the working, different balloons, scoring and cracking balloons, using different kinds of drugs in combo with those scoring balloons, and devices which will be more easier, safer, and effective. Thank you very much.
Thanks so much.